Hello and welcome to our last section of our Chapter 18 video lecture series, Section 18.5 on vaccines. So what we need to know here is that vaccines are a form of artificial immunity, and it's going to stimulate our adaptive immune defenses, which is what's so helpful because we are able to trigger memory cell production, which is similar to what would happen if we were to be infected by a pathogen in their primary response. So when we have a vaccine, we are able to create a strong secondary response without actually experiencing the primary response. So let's look at our learning objectives first. We want to compare the various kinds of artificial immunity, differentiate between variolation and vaccination, and describe different types of vaccines and explain their respective advantages and disadvantages. So we'll start off just describing what classifications of adaptive immunity we have. We have our active and passive immunity. So what we mean by active immunity is that we're able to use our own adaptive immune defenses as if we were just infected with a pathogen, and this is how we would naturally respond to it. With passive immunity, we're transferring adaptive immune defenses from one individual or an animal into our body. So we could do this either naturally or artificially. So let's first take a look at natural immunities. Natural active immunity is going to develop after we are naturally exposed to a pathogen. When we have natural passive immunity, it means that we are able to pass on antibodies to another individual, and in most cases it's going to be an infant. So examples would be when we have IgG crossing the placenta from mother to the fetus, and then we have IgA passing in breast milk if the woman were to breastfeed. Next, we have our two artificial types of immunity. So artificial passive immunity means that we're able to transfer antibodies produced by a donor to another individual. So we tend to do this after we're exposed to something. So for example, if we have been exposed to rabies, hepatitis A, hepatitis B, and the chicken pox, to help the individual recover, we can also do this in a case where someone is seeking treatment of being infected by tetanus, botulism, or diphtheria, and the bacteria are releasing bacterial toxins, so we can kind of combat it in that way. And then we've got our artificial active immunity, and this is where vaccines come in. Again, we're activating our adaptive immune system by exposing the individual to a weakened or an activated pathogen or some of the key pathogen antigens, so that internally we are creating memory immune cells to this pathogen, but we're not actively feeling the signs and symptoms. Next, let's talk about the term herd immunity. This takes place because there are too few susceptible individuals in our population for the disease to spread effectively. So we see this in this group over here, where we have a number of individuals that are immune, some that are susceptible, and you can see very minimal that are infected. When there's no herd immunity, then we're able to spread that disease to many susceptible individuals. So our vaccination programs are created to promote herd immunity so that we can reduce the amount of individuals that are susceptible to a particular pathogen. Now we're going to have a bit of storytelling with variolation and vaccination. So thousands of years ago, people did realize that individuals who were able to survive smallpox were immune. And so in the 10th century in China, variolation was practiced. They would deliberately inoculate individuals with infectious material from the scabs and the pustules of people that already had smallpox. And what they would find is the individuals that went through variolation had a milder and started getting a naturally acquired smallpox defense. And most people were able to tolerate the variolation, although there were some more serious and fatal infections that did take place. Then in approximately 1796, Edward Jenner was credited by developing modern vaccination. He noticed that cow milkers who developed a milder cowpox illness were immune to the more serious smallpox disease. And he thought if he was able to obtain some of the infectious samples of a person with active cowpox lesions, which is what we're seeing here, and injecting the materials into another individual, which happened to be a young boy, they would develop a mild infection, low-grade fever, maybe discomfort in the armpit, and loss of appetite. And later, if they were to become infected by smallpox, they did not have smallpox. They were immune to it. And so lucky for that young boy that his hypothesis was true and vaccinations therefore were created. And the reason we call this vaccination is because of cowpox, because in Latin, vaca means cow. And later we would understand that the cowpox virus is genetically and antigenically related to the variola viruses that caused smallpox. Later, around 1879 plus, so more in the 1880s, Louis Pasteur then developed vaccines for rabies, cholera, and anthrax. Which brings us to our classes of vaccines. There isn't just one way to create a vaccine. We've got all these different options here, and we'll start with our live attenuated vaccines. This exposes an individual to a weakened strain of the pathogen, so we might have more of a subclinical infection. So we're able to activate our adaptive immune defenses, which include both cellular and humoral immunity, and stimulate the development of our memory cells for long-lasting immunity. Now, there are some challenges in being able to have long-term storage and transport for these vaccines, and patients can develop some signs and symptoms of the disease, and there's a possibility of that pathogen reverting back to its full virulence and causing the disease to actually take place. Then we have our inactivated vaccines. This contains the whole pathogen, but the pathogen has been killed or inactivated with heat, chemicals, or radiation. These types of vaccines only involve stimulating our humoral immunity, so we will need higher doses or multiple boosters after the initial vaccination, which can cause some inflammatory reactions in the site of the injection. What's good is that we can have these vaccines being stored long term, they're easily transported, and there's no risk of causing a severe reaction. With our subunit vaccines, we're only exposing that patient to key antigens of the pathogen, not the whole cell or the whole virus. And this is done by genetic engineering, and typically the side effects are pretty low. Next, we have our toxoid vaccines, and these contain inactivated toxoids or bacterial toxins that are used to prevent the disease. This, once again, will activate only the humoral immunity and will work to neutralize the toxins that are produced by the bacterial cells. And lastly, we have our conjugate vaccine. This is a type of subunit vaccine that's consisting of a protein conjugate to a capsule polysaccharide. So this type of vaccine is typically used to help the efficacy of a subunit vaccine and are used for pathogens that have that polysaccharide capsule. Remember the capsule that goes around the bacterial cell and it makes it really difficult for phagocytes to engulf it, kind of like a slippery bar of soap. So this type of vaccine will then produce antibodies that can opsonize the capsule and combat the infection. There is a warning though with these, not to use them in children under the age of 2 that can't respond properly to these vaccines. On the next slide here, we have a table that gives a summary of what we've discussed and a little bit of extra detail as far as some examples. Lastly, let's talk about our clinical focus and the resolution. So the preliminary diagnosis is going to be bacterial meningitis, even though the labs weren't back quite yet. So they admitted Olivia into the hospital and started giving her intravenous broad-spectrum antibiotics and rehydration therapy. She started to improve, and the new blood samples and lumbar puncture samples showed that there's an absence of microbes, and the white blood cell levels came back to normal. And once the previous labs came back, there was positive identification of Neisseria meningitidis, which is the causative agent to meningococcal meningitis, and that produces a polysaccharide capsule. So in the US, it's recommended that the vaccine be administered to children of ages 11 to 12 with a booster at age 16. So Olivia, of course, has not received that vaccine yet because she's still an infant, and she's starting to lose her natural passive immunity that was given to her mother through that IgG, right? And possibly IgA. So this does tend to affect infants because of that.